Welcome to this lecture on gynecological anatomy, development of the female pelvic organs, malformations of the female genital organs. I am Professor Olusola Fashuba of the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. At the end of this lecture, you should be able to describe the constituents of the external and internal genitalia, their blood supply, the pelvic lymphatics, and the nerves of the pelvis. 2, you must be able to describe how the internal and external genitalia are developed. And 3, you must know the various malformations of the female genital organs, their presentation and treatment. These are the 3 learning outcomes of this lecture. A clear understanding of the pelvic anatomy is crucial to making a gynecological diagnosis, and it is essential for basic gynecological surgery. The female pelvis is like a bowl that is reinforced on the inside by muscles, fascial and peritoneum, and on the outside by muscles, fascial and the skin. Again, the female pelvis is like a bowl reinforced inside by muscles, fascial and peritoneum, and the outside by muscles, fascia, and the skin. And it has a pelvic diaphragm which separates the internal genitalia from the external genitalia. The bowl constitutes the pelvic bones or skeleton, which is formed by the sacrum and coccyx posteriorly, and the paired hip bones called innominate bones laterally, which fuse anteriorly to form the pubis symphysis. This is the innominate bones. This is the innominate bones, and they form the boundary of the pelvic bone laterally. And this innominate bone is made up of 3 separate bones: the ilium, the ischium, and then the pubic bone. 3 bones. So this is just the lateral aspect of the innominate bone, a combination of 3 separate bones that form the lateral boundary of the pelvic bone. As I've said, the innominate bone consists of the ilium, the ischium, and the pubis. The 3 components meet at the acetabulum. This is the acetabulum. This is the acetabulum, where the 3, you can see the portion of the ilium, the portion of the ischium, and then the portion of the pubic bone. The iliac crest is the most prominent feature, which provides attachment to the iliac fascial, abdominal muscles, and the fascial lata. Projections at each end of the iliac crest are the anterior and posterior iliac spines. The medial surface articulates with the sacrum posteriorly. The medial surface of the ilium articulates with the sacrum posteriorly. The ischium, again, the ischium This, from this boundary, this is the ischium. This is the ischium. This is the ischium. The ischium consists of a body and a ramus. The body forms part of the acetabulum, and the ramus fuses with the ramus of the pubis to complete the obturator foramen. The ischial spine delineates the greater and lesser sciatic notch above and below it. The ischial spines delineate again. This is the ischial spine. This is the ischial spine. This is the ischial spine. And this is the greater, all these areas are the greater sciatic notch. And these other ones, this small one is the lesser sciatic notch. It's a notch, but this, the greater sign is great, you know, and you can see it. The ischial spine has some anatomical significance in obstetrics. It has some clinical significance in obstetrics. One, it's a clinical landmark on pre-vaginal examination for detection of progress of fetal descent in labor. It's a clinical landmark on pre-vaginal examination for detection of progress of fetal descent in labor. In this case, we want to see whether the fetal descent is high or low in the pelvis. It is also useful in assessing the capacity of the mid-cavity in clinical pelvimetry. It's useful in assessing the capacity of the mid-cavity in clinical pelvimetry. For instance, in the normal gynecoid pelvis, the ischial spine is less prominent. In the normal gynecoid pelvis, the ischial spine is less prominent. Whereas in the android pelvis, the male type of pelvis, the ischial spine is more prominent. It can also serve as a landmark in the performance of pudendal nerve blockage in obstetric anesthesia. It can also serve as a landmark in performance of pudendal nerve block in obstetrics. So, three things are important. The ischial spine is significant in three respects: in determining the level of descent in labor, and it's useful to determine the capacity, assessing the capacity of the mid-cavity in clinical pelvimetry, and it's also important in the performance of pudendal nerve blockage in obstetric anesthesia. The ischial tuberosity is a rounded, bony prominence upon which the body rests in the sitting position, and this is also useful in clinical pelvimetry. This is the body. This is the sitting position, that we're talking about. This is the body of the ischium, and the ischial tuberosity, which you can accommodate the knuckle of the finger. If you can accommodate the knuckle of the finger, we are talking that the external outlet of the pelvis is adequate. The pubic consists of a body and two rami. The superior rami joins the ilium. And ischium to form the acetabulum. The inferior ramus of the pubis joins the ramus of the ischium to complete the obturator foramen. And the upper part of the body forms the pubic crest and the pubic tubercle. And the medial surface forms a cartilaginous joint with the opposite pubis, the pubic symphysis. The sacrum, which is the posterior boundary of that bole, consists of 5 sacral vertebrae in adults. 5 sacral vertebrae in adults. the upper border of the sacrum is the sacral promontory. The upper border of the sacrum is the sacral promontory. And the sacrum articulates above with the fifth lumbar vertebrae, laterally with the ilium, and below to the coccyx, which are about 3 to 5 fused coccygeal vertebrae. So we have described the skeleton of the pelvis, upon which that serves as the basis, which the pelvis, which accommodates the reproductive system. So we're going to talk about the anatomy of the external genitalia now. The reproductive system consists of the external genitalia and the internal genitalia. The reproductive system consists of the external genitalia and the internal genitalia. The external genitalia now, sometimes called the vulva, or the pudendum. This comprises of the whole of external genitalia, the urogenital triangle, and the perineum. This is the vulva. Consists of the urogenital triangle. This is the area of the urogenital triangle. Yes, this is the area of the urogenital triangle that is called the vulva. And that external genitalia also includes the perineum here. Look at the perineum. Look at the perineum, this section. So the external genitalia comprises of all the structures here down to this place, just superior to the anus. This is the anus. This is the anus. So this area is the perineum. The external genitalia is the perineum plus this anterior the urogenital sinus, the urogenital triangle. So the vulva comprises of the whole of the external genitalia or the urogenital triangle and the perineum. And the perineum consists of superficial and deep perineal compartment. The vulva is banded superiorly by the mons pubis, and inferiorly by the perineum. This is the mons pubis. This is the mons pubis. This is the mons pubis, which is an area above the pubis symphysis, this area, and then the perineum, as I've explained earlier. Superiorly by the mons pubis and inferiorly by the perineum. Yes. So the mons pubis, which is the area, it consists of the fibrofatty tissue, which covers the bodies of the pubic bones. The mons pubis is that area that covers the bodies of the pubic bones, and it consists of fibrofatty tissue. Inferiorly, the mons pubis divides to become and continuous with the labium majus on each side of the vulva. It divides inferiorly and becomes continuous with the labium majus on each side of the vulva. The skin that covers the mons pubis bears the pubic hair, and the hair is horizontal in its upper part. The skin that covers the mons pubis bears the pubic hair, and the hair is horizontal in its upper part. The labia majora are two folds of skin and subcutaneous fat which merge posteriorly into the perineum, where they are joined together by the fourchette. And the skin covering them contains sebaceous and sweat glands and a few specialized apocrine glands, from which a tumor known as hydrandenoma may arise. The round ligament terminates in the fatty tissue of the labia majors. The labia minora, there are two thin folds of skin to the labia minora. Look at this. This is the labia majora, which I've described. And we said this area is covered with skin. And this medial portion is the labia minora. It's a thin fold of skin, of tissue. You can see it. And even on this side too, this is the labia. This is the labia majora, and this thin fold of skin is the labia minora. The labia minora are two thin folds of skin which lie between the labia majora. Anteriorly, they divide into two parts, the upper of which unite over the clitoris to form the prepuce, and then the lower unite to form the frenulum. The skin of the labia minora bears no hair follicles. The skin of the labia minora bears no hair follicles, as opposed to the skin of the labia majora, which has hair follicles. The labia minora are very sensitive and contain some erectile tissue. They are very sensitive and they contain some erectile tissue. The clitoris consists of three parts: the glans, the body, and two crura, which diverge posteriorly to be attached to the rami of the pubic bones. The glans contain many nerve endings. The body and crura are composed of erectile tissues. The crura are surrounded by the ischiocavernosus muscles, the contraction of which produces erection of the clitoris. The vestibule is banded anterolaterally by the labia minora and posteriorly by the fourchette. The urethra, the ducts of the Bartholin's glands, and the vagina open into the vestibule. The urethra, the ducts of the Bartholin's gland, and the vagina opens into the vestibule. Again, let me repeat. The anterolateral boundary of the vestibule is the labia minora, and posteriorly by the fourchette, where the labia majora join together. The vestibular bulbs are two oblong masses of erectile tissue which lie on either of the vaginal entrance. They are covered by the bulbospongiosum muscles. The Bartholin's gland, which is the vestibular glands, are two racemose glands situated on either side of the vaginal orifice, deep to the posterior ends of the labia minora. They secrete a thin mucus which acts as a lubricant during sexual excitation. The gland cannot be palpated unless it is pathologically enlarged by inflammation or by new growth. So let's have a look at this. Again, this is a labia minora. There's a labia minora here on both sides, and this portion is the vestibule. Yes, and this vestibule, that's what the vagina opens into, just a potential space. And down here, you have the Bartholin's gland and vestibular bulbs. Right, and vestibular bulbs. Yeah. The hymen is a membrane of connective tissue covered by stratified squamous epithelium. It is perforated centrally and the opening varying in size to allow the passage of menstruum. The hymen is partially ruptured at the first coitus and further destructed during childbirth. The superficial perineal muscles lie superficial to the urogenital diaphragm. It is pertinent to know the various structures of the external genitalia. So in summary again, the external genitalia or the vulva or the pudendum consists of the mons pubis, the labia majora, the labia minora, yes, the vestibule, the vestibule into which the urethra opens, the vagina opens into it, and then the ducts, the Bartholin's duct opens into it. It also has an hymen. You can see the hymen, which is destructed at the first intercourse or can further destroyed with parturition. So we also have the clitoris as part of the constituents of the vulva, and you have the pubis above it, which is a division of the labia minora. The device, we told the labia minora divides superiorly, and the upper part of it covers the clitoris to form the pubis, and inferiorly to the clitoris to form the frenulum. So, in describing the anatomy of the vulva, all these structures need to be mentioned. And you can see the same thing here too. Yes, the constituents of the urogenital triangle, the muscles, which we have mentioned. What are the vascular supply of the vulva? The vulva is highly vascular. The arterial supply of the vulva is from the internal pudendal artery. Which is a terminal branch of the internal iliac artery. The arterial supply is from the internal pudendal artery, which is a terminal branch of the internal iliac artery. It also receives branches from the superficial and deep pudendal arteries, which are branches of the femoral artery. It also receives branches from the superficial and deep pudendal arteries, which are branches of the femoral artery. So two major supplies from the internal iliac artery anteriorly and from the femoral artery inferiorly. The veins accompany arteries of the internal pudendal arteries and those of the superficial and deep pudendal to the femoral veins. And the lymphatic supply of the vulva. The lymphatic supply drains mainly to the superficial inguinal nodes. The lymphatic drainage of the vulva drains mainly to the superficial inguinal nodes. And from the superficial inguinal nodes, they drain into the deep inguinal nodes before entering into the external iliac group of nodes. And those from the deep tissue accompany the internal pudendal vessels to the internal iliac nodes. And from there, they go harbor to the aortic group of lymph nodes, and then to the cyst, from the sister chela. The nerve supply of the vulva. Again, just as we have said that the vulva is very rich in vascular supply, so also the vulva is exceedingly rich in nerve supply. The skin of the mons pubis and the upper parts of the vulva are supplied by the ilioinguinal nerves and the genital branch of the genitofemoral nerve. Again, the skin of the mons pubis and the upper parts of the vagina are supplied by the ilioinguinal nerve and the genital branch of the genitofemoral nerve. The posterior inferior part of the vulva is supplied by the pudendal branch from the posterior cutaneous nerve of the thigh, and then the labia and perineal branches of the pudendal nerve. So the skin of the vulva is very sensitive, and perineal injuries are especially painful because as a result of these 4 different types of nerves. The discomfort, which results from the perineuraphy or episiotomy, is due to spasm in the underlying muscles. I repeat that the nerve supplies of the external vulva of the vulva are from the ilioinguinal nerve, the genital branch of the genitofemoral nerve, the pudendal branch from the posterior cutaneous nerve of thigh, and then the labia and perineal nerve from the pudendal nerve. So, the internal genitalia. The internal genitalia. The internal genitalia comprises of the vagina, the uterus, the fallopian tubes, and the ovary. Look at this. This is the ovary. This is the ovary. This is the fallopian tubes. This is the fallopian tube on the left, and also on this side. This is ovary on this side. And this is the uterus. So this is the uterus, yes, and this is the vagina. So the internal genitalia comprises of the vagina, the uterus, the fallopian tubes, and the ovary. This is the word that is internal, that is inside. And on this side, you can see, so this is what, that's why, because they are inside, you cannot see it. They are called internal genitalia. And the one you can see outside, the vulva and all the rest that we have just described, they constitute the external genitalia. Vagina is a hollow fibromuscular tube extending from the vulvar vestibule to the uterus. It extends from the vulva to the uterus. The vagina constitutes the excretory channel for the uterine secretion and menstrual blood. It constitutes the excretory channel for uterine secretion and the menstrual blood. It is the organ of copulation and for birth canal at parturition. It has an anterior and posterior and 2 lateral walls. It has an anterior, posterior, and 2 lateral walls. And it is lined with squamous epithelium. It is lined with stratified squamous epithelium. The average length of the vagina is about 10 centimeters. The anterior and posterior walls are normally in apposition. They are normally in apposition. And the posterior wall is longer than the anterior wall. The posterior wall is longer than the anterior wall. The cervix, the uterine cervix from the uterus projects into the vaginal vault to form 4 fornices, an anterior fornix, a posterior fornix, and 2 lateral fornices. Again, the cervix projects from the uterus into the vaginal vault to form 4 fornices, anterior fornix, posterior fornix, and the 2 lateral fornices. The vagina has no glands. Unlike the uterus and cervix, that you can see some glands, secretory glands. Laterally, the vaginal wall is supported by the cardinal ligaments. Laterally, supported by the cardinal ligament, sometimes called lateral or transverse cervical ligament, or the parametrum. And the medial edges of the levator ani muscles support the mid-third of the vagina. The medial edges of the levator ani muscles support the mid-third of the vagina. And posteriorly, the lower part of the vagina is supported by the perineal body, which is formed by the decussating fibers of the levator ani muscles and the superficial and perineal muscles. So the vagina has three supports. Anteriorly, in the upper part of the vagina, by the cardinal ligaments, and in the medial portion by the levator ani muscles, and inferiorly by the decussating fibers of the levator ani muscles, the superficial and perineal muscles. So this must be noted. These three supports of the vagina must be in the upper part by cardinal ligaments, the middle portion by the levator ani muscles, and inferiorly, which is the lower portion, by the decussating fibers of the levator ani muscles and the superficial and perineal muscles. These three areas hold the vagina in support, and they are very important if there is a uterovaginal prolapse. The rectum forms its posterior relation, that is, posterior boundary of the vagina is the rectum, and anterior boundary of the vagina is the bladder. So that completes the description of the vagina. We are going to talk about the vascular supply later in association with other forms of the genitalia, other parts of the genitalia. The uterus is a hollow, smooth muscle organ. The uterus is a hollow, smooth muscle organ. It is lined by a glandular epithelium called endometrium and almost entirely covered by a densely adherent peritoneum. It's lined by a glandular epithelium called endometrium and almost entirely covered by a densely adherent peritoneum. The uterus weighs about 70 grams and is about 7.5 centimeters long and has walls about 2 centimeters thick. It is roughly pear-shaped. It consists of two unequal parts. The upper portion called the corpus or body, which is about 5 centimeters long, and a lower portion or the neck called the cervix, which is about 2.5 centimeters long. Then the corpus uteri, which is the upper part of the uterus. The anterior and posterior walls of the uterine cavity are normally in contact. The anterior and posterior walls of the uterine cavity are normally in contact. The cavity of the corpus uteri is triangular, with the base uppermost and the apex at the junction of the cervix, where it is narrowed to form the internal os. The cavity of the uterus is triangular. The corpus uteri is triangular, with the base uppermost and the apex at the junction of the cervix, where it is narrowed to form the internal os. At the upper angles are the openings of the fallopian tubes. And the part of the uterus above the opening of the fallopian tube is called the fundus. From puberty to menopause, the endometrium, which is the internal lining of the uterus, undergoes cyclical changes. And after menopause, the endometrium atrophies and becomes a thin layer with a few residual glands. That's about corpus uteri. So, what about the cervix uteri, which we refer to as the neck of the uterus? The cervix is cylindrical in shape and is continuous with the body of the uterus. I said it's about 2.5 centimeters long, while the corpus uteri is about 5 centimeters long. The cervix uteri has two parts. The supravagina, the part above the vagina, supravagina, and then the vaginal part. The vaginal part projects into the vault of the vagina. The vaginal part projects into the vault of the vagina to form the 4 fornices we have described earlier on. The cervical canal is spindle-shaped, being concentrated above at the level of the internal horse and below at the external horse, where it opens into the vagina. In the nulliparous woman, the external horse is circular, while in the multiparous woman who have born one or more child, it becomes a transverse slit. The vaginal surface of the cervix is covered with squamous epithelium. The vaginal surface of the cervix is covered with squamous epithelium, and the cervical wall consists of fibromuscular tissue and its canal lined by tall columnar epithelium. Please note, two epithelia could be seen in the cervix uteri. In the supravaginal portion of the cervix, it is lined by tall columnar epithelium, and the vaginal aspect is lined by squamous epithelium. The junction at which the squamous epithelium meets with the tall columnar epithelium is called the squamocolumnar junction. It's called the squamocolumnar junction or the transformation zone. The junction at which the squamous epithelium and the columnar epithelium meets is called the squamocolumnar junction or the transformation zone. This zone is very, very important in the etiology of carcinoma of the cervix. Sometimes this transformation zone may not be visible, may be a little bit inside the cervix, or can be advanced to the vaginal part of the cervix. So when we are doing procedures like screening the Papa Nicholas smear, one has to be careful and to ensure that this transformation zone is perfectly seen. The uterus as a whole may be anteverted with the long axis directed forwards or antiflex, but with the body bent forwards. And the opposite condition is called retroversion with retroflexion. In about 70% of women, about 70 to 80% of women, the uterus is directed forwards and bent forwards. That is anteversion and anteflexion. And rather, in the 20% of women, they could be retroverted and retroflexed. The uterine artery passes medially to reach the uterus at about the level of the internal horse. At this point, the ureter passes forward below the artery at a distance of about 2 centimeters from the side of the cervix. This statement that I've just made is important when one is trying to do the operation called hysterectomy, so that the ureter is not injured. The fallopian tubes, or otherwise known as the uterine tubes. The fallopian tubes, or otherwise known as the uterine tubes, is the third component of the internal genitalia. Each fallopian tube extends outwards from the uterine cornu to end near the ovary opening into the peritoneal cavity. The tubes convey the ovum from the ovary towards the uterus. It provides oxygenation and nutrition for sperm. Ovum, and zygote should fertilization occur. It is also the site of fertilization. The tubes are completely covered by peritoneum at the upper margin of the broad ligament, The tubes are completely covered by peritoneum at the upper margin of the broad ligaments. And the tubes is about 10 centimeters long and are described in 4 parts. The medial aspect, the most medial aspect, the interstitial portion, which is within the body of the uterus. The interstitial portion is within the body of the uterus, about 1 to 1.5 centimeters long. And then the isthmus, which is the next line to it, laterally, is lateral to the interstitial portion, and followed by the ampulla, and then finally by the infundibulum or the femoral portion, which is the most outer portion, very near the ovary. The ovaries is the 4th part of the internal genitalia. The ovaries. There are 2 almond-shaped solid organs, measuring about 3.5 centimeters in length, 2 centimeters in depth, and 1 centimeter in thickness. There is one on the left, there is one on the right. They are smaller in the female child, about 1.5 centimeters long, containing between 1 to 2 million primordial follicles. They increase in size in adulthood due to proliferation of the stroma cells. The position of the ovary varies considerably, but usually lies against the peritoneum of the pelvic wall in the ovarian fossa. The ovary is banded above by the external iliac vein and behind laterally by the ureter, and the ovary is not covered with peritoneum. The ovary is not covered with peritoneum. It is attached at its hilum to the posterior surface of the broad ligaments. The other structures in the pelvic are the bladder, urethra, and ureter. The other structures in the pelvic that are called as pelvic structures are the bladder, the urethra, and part of the sigmoid colon. So, what are the arterial supply of this internal genitalia? What are the arterial supply of this internal genitalia? The arterial supply of these pelvic organs are derived from the branches of the anterior division of the internal iliac artery. The arterial supply of the pelvic organs are derived from the branches of the anterior division of the internal iliac artery. For this internal genitalia, we have uterine artery, vaginal artery, the vesical artery, the middle hemorrhoidal artery, and the pudendal artery, all from the branches from the anterior division of the internal iliac artery, supplying the uterus, the cervix, the vagina, the bladder, and then the external genitalia as previously described. The ovarian artery arises purely from the aorta, just below the renal arteries. The ovarian artery arises directly from the aorta, just below the renal arteries. And this ovarian artery also supplies the lateral part of the fallopian tube. So the fallopian tube receives 2 arterial supplies, one from the uterine artery and the other from the branches of the aortic artery. The venous drainage of this internal genitalia is into the internal iliac veins. The venous drainage is into the internal iliac veins, following the various arteries, the uterine artery, the vaginal artery, the vesical artery, the middle hemorrhoidal artery, and the pudendal artery to enter into the internal iliac veins, and before they enter into the main venous supply. The pelvic lymphatics. The pelvic lymphatic drainage the lymph draining from the lower extremities. The lymph draining from the lower extremities and the vulva and perineal regions filtered through the inguinal and superficial femoral nodes to enter into the external iliac group of nodes. From the external iliac group of nodes, they ascend to the common iliac group of nodes. And then from the common iliac group of nodes, they go up to the para-aortic groups of lymph nodes. Again, the lymphatic drain from the lower extremities of the vulva and the perineal regions, they filtered through the inguinal and superficial femoral nodes to enter to the external iliac group of lymph nodes. From external iliac group of nodes to common iliac group of lymph nodes and the para-aortic groups of lymph nodes. Medially, those organ structures, another chain of vessels passes from the deep femoral nodes to the femoral canal to the obturator group of lobes, and from there they ascend to the internal iliac groups of nodes. And from the internal iliac group of nodes, they enter into the common iliac and para-aortic nodes. And from the para-aortic group of nodes, they enter into the cistern chalae, thorax duct, to the left subclavian and internal jugular veins. This is the group which the lymph nodes have just described. So the lymph nodes, all those from periphery, the deep femoral nodes, deep femoral nodes, so those coming down, and they enter to the node of Cloquet, you can see, to the obturator groups of lymph nodes, and from there they go to the external iliac group of nodes. And those that come medially also go into, you can see it, to the internal iliac group of nodes, to the para-aortic, to the common iliac node, from the common iliac nodes to the para-aortic nodes. This is also the diagram showing the nerve supply of the pelvic organs. You can see the uterus, you can see the sacral sympathetic lymph nodes modulates the nerve supplies, usually from the sympathetic, both sympathetic and parasympathetic group of nerves. Yes, we have described the surface anatomy of the external genitalia and the internal genitalia, situated within a bowl, the pelvic skeleton. So we're going to talk about development of the pelvic organs now. We're going to talk about developments about embryology of both the internal and external genitalia. The internal genitalia begins to differentiate and become identifiable in the 5th week of intrauterine life, when the embryo is approximately 10 millimeters long. Again, the genital organs begin to differentiate and become identifiable in the 5th week of intrauterine life, when the embryo is approximately 10 centimeters long. This diagram shows steps in the formation of the broad ligament, right? Yes. At this 5th week, the primitive gut is suspended from the dorsal aspect of the coelomic cavity in the midline. Look, the primitive gut. This is the primitive gut that is suspended in the coelomic cavity when the embryo is about 10 centimeters long. And look at the longitudinal ridge that is lateral to it on both sides, from where the ovary, the site of the ovary, yes, and then the mesonephric is formed. This ridge, this lateral ridge, is the mesonephros. On both sides, mesonephros, that gives rise to this. Later, we'll talk about it later. At the Wolffian mesonephric, at this stage, the primitive gut is suspended from the dorsal aspect of the coelomic cavity, as I pointed earlier, by mesentery, and is flanked on either side by a longitudinal ridge covered by coelomic epithelium. This longitudinal ridge is produced by the mesonephros. The Wolffian duct lies on the lateral side of it, of that. So let's have a look. This is the lateral ridge on this side, on both sides. And look at the position of the mesonephric duct, which is lateral to that ridge. And that's the side of the Wolffian duct, which will give rise to the male reproductive structures. I need to point out that if the sex of the fetus depends on the type of chromosomes that are present. If the chromosomes that are present is XY, if the male type of chromosomes, the mesonephros regresses. But if it's an XX chromosomes, the mesonephros develop. So since we are talking about the female pelvis, the mesonephros takes preeminence and grows, while the suppression of the Wolffian system takes place because of the ability of the XX chromosomes to suppress it. The coelomic epithelium on the medial side of the mesonephros proliferates into several layers and cores of cells, extend into the underlying mesoderm, which also increases considerably to form a prominent swelling on the medial side of the mesonephros called the genital ridge. That genital ridge is the fusion site of the ovary. Look at this, the genital ridge, which proliferates and cores of cells migrates into it from the coelomic epithelium, called the ova, and they produce the fissure ovary. At the same time the ovary is being formed, a groove of coelomic epithelium becomes invaginated into the lateral side of the mesonephros. Again, let's go back. You can see the group. We've talked about the mesonephric Wolffian duct here. That a group of Mullerian duct now begins to form here, and they continue to grow downwards. They grow caudally on both sides. They grow caudally until they meet and then fuse together to form what the body of the uterus, and from the body of the uterus. And the upper part of that growth forms the fallopian tubes, but where they meet to form the uterus. Let's go ahead again. At the same time the ovary is being formed, a groove of coelomic epithelium becomes invaginated to the lateral side of the mesonephros. From this groove, a solid core of cells extend in a caudal direction inferiorly, running close to the lateral side of the Wolffian duct. Later, this core canalizes but retains its communication anteriorly with the coelom. This is the Mullerian or paramesonephric duct. This is the Mullerian or paramesonephric duct, which will form the fallopian tubes, the uterus, and the upper vagina. The anterior end will become the ostium, and around this is the fimbria. The fimbria will develop later. The Mullerian and Wolffian ducts are separated from the dorsal wall by a broad mesentery. In the pelvic region, the free edges of the genital mesentery incline medially. They meet and fuse in the midline to form a septum between the hindgut, which later forms the rectum, and the urogenital sinus, which will form the bladder and the urethra. In this septum, the Mullerian ducts pass medially across the front of these Wolffian ducts and also meet and fuse in the midline. They then turn caudally again as a single solid rock of cells and extend until they make contact with the urogenital sinus. They produce a prominent elevation in its posterior wall, the Mullerian tubercle. The result of cells regresses, and a solid cord of epithelial cells derived from the urogenital sinus grow upwards in its place, extending as far as the cervix. So, in this essence, you know that the vagina is formed from the Mullerian structure and part of the urogenital sinus. The central cells of this cord break down to form the lumen of the vagina. The hymen marks the site from which this upward growth of urogenital sinus cell began, the surrounding mesoderm of the genital septum. And the ovary and the upper part of the Mullerian duct, which becomes the fallopian tube, develop in the upper part of the coelom and receive their blood supply from the corresponding segment of the aorta. The mesonephros degenerates almost completely, but a few tubules persist in the broad ligament, where they may give rise to cysts in adult life. In the male, the Wolffian duct forms the wall, the vas deferens, but degenerates in the female fetus. It can sometimes be traced in the adult female, when it is known as Gardner's duct. How is the external genitalia formed? We have described how the internal genitalia forms from the pronephros. Now, this diagram shows the stages of development of the external genitalia at 7 weeks, at 10 weeks, and at 12 weeks. At 7 weeks, at 10 weeks, and at 12 weeks. The urogenital sinus, which forms the bladder, urethra, and vestibule, develops as a ventral diverticulum from the hindgut. At first, the urogenital sinus and hindgut open into a common cavity called the cloaca, which is separated from the exterior by the cloacal membrane. Later, the urogenital sinus is completely separated from the hindgut by a septum of mesoderm, which divides the cloacal membrane into a posterior part which temporarily closes the future anus, and anterior part, the urogenital membrane. In front of this urogenital membrane arises a midline tubercle, the phallic tubercle. So that is in front of the urogenital membrane arises a midline tubercle called the phallic tubercle. This is the phallic tubercle. This is the phallic tubercle. Yeah. Front of the urogenital membrane. Front of the urogenital membrane arises this formation, the phallic tubercle. On either side of the two ridges develops the inner ridge called the genital folds, and the outer ridge called the genital swelling. Inner folds, the inner ridge. Out of this, you see out of this ridge, out of this, you have the inner fold, a longitudinal ridge, the genital fold, which is inner, and the outer, called the genital swelling. This is the genital swelling, and this is the inner ridge. And this is the inner ridge. The phallic tubercle eventually forms the clitoris. The phallic tubercle eventually forms the clitoris. And the genital swelling, this genital swelling forms the labia majors. And then the genital fold eventually forms the labia minora. While the outer genital swellings give rise to the labia majora, the inner folds give rise to labia minora. And finally, the urogenital membrane disappeared so that the vestibule communicates with the exterior through the vulva. Concept, the urogenital membrane disappeared so that the vestibule communicates with this is the urogenital membrane. This is the urogenital membrane. Later, with the formation of the labia majora and then the labia minora, the urogenital membrane disappears so that the vagina can now open into the exterior. And that completes the formation of the external genitalia. So by the end of the 12th week, the internal genitalia and the external genitalia has been completely formed. So the internal genitalia begins the race and is completed with the external genitalia. Resulting from this embryological development, a lot of deformities of the external genitalia and a lot of deformities of the internal genitalia can arise. What are the deformities of the vulva that can arise as a result of maldevelopment of the external genitalia? The first of these, there may be the opening of the hymen may be very small or cribriform. The opening of the hymen may be very small, or the hymen may not perforate at all, that we call imperforate hymen. We call imperforate hymen. And this may, in later years, cause a dampening of menstruation. The woman, when it gets to the age of menstruation, does not menstruate, and causes what we call cryptomenorrhea or hematococcus. A membrane may obstruct the entrance to the vagina, and usually this may occur above the hymen, which may give rise to hematococcus. There may be congenital enlargement of the labia minora. And again, there could be hypertrophy of the clitoris as seen in virility conditions caused by androgens secreted by adrenal cortex or ovarian tumors. And these are sometimes seen in cases of intersex. So again, there could be perforate hymen, there could be a membrane or a thick tissue obstructing the entrance of the vagina. There could be congenital enlargement of the labia minora, and can be hypertrophy of the clitoris. Some of these are deformities that you can see in the vulva, resulting from congenital malformations of the female genital organs. In the vagina, you can have gynatresia, congenital gynatresia, resulting in vaginal atresia or non-canalization of the vagina. Yes, those are common, and also they can give rise to, they can exist in condition where there is congenital absence of the uterus and fallopian tubes, congenital absence of the vagina as well. In situations we refer to as Oster-Koster Meyer syndrome. Meyer-Oster-Koster syndrome. So, in which case there is no uterus, no cervix, no vagina. And sometimes all those uterus, cervix could be present, but the vagina is not canalized, or vagina is completely absent. There could be failure of fusion resulting in double vagina. There could be failure of fusion resulting in double vagina. Particularly when the mullerian structures are coming medially and there is failure of fusion. There could be absence of the vagina. Obstructing membrane or partial atresia leading to cryptomenorrhea and subsequently to hematocorpus can also be present in the vagina. Deformities of the uterus. As I said earlier, the uterus could be completely absent or rudimentary in nature. The uterus could be completely absent or rudimentary in nature. There could be failure of fusion of the Mullerian ducts that leads to duplication of the uterus and vagina. And when you have this type of failure of fusion of the Mullerian ducts, most of the time, there are associated abnormalities of the ureters and the kidneys. There are associated abnormalities of the ureters and the kidneys, pelvic kidneys, and absence of the ureter sometimes. And this failure of fusion can give rise to the following: uterus didelphys. Uterus didelphys, in which case there is complete lack of fusion of the Mullerian ducts, with a double uterus and a double vagina. Uterine didelph is a situation where you have a double uterus and double vagina. 2, it could also result in uterus bicornis bicolis. Uterus bicornis bicolis. There are 2 horns of the uterus and they are separate. 2 horns of the uterus are separate, but there is some fusion of the muscular walls and the cervix is double. There could be some fusions of the muscular walls of the uterus and the cervix is double. So incomplete fusion. There is what we call uterus bicornis unicolis. The body of uterus is bifid, but the cervix is normally developed. Uterus bicornis unicolis. The uterus is bifid, but the cervix is normally developed. There is what we call uterus unicornis. Uterus unicornis. Only one of the Mullerian duct has developed to produce fallopian tube, uterus, and vagina. And the second duct may be present in a rudimentary form. And the uterus septus, the ducts are fused externally. The uterine cavity is partly or completely divided by a median septum. The vagina may be septate. This is sometimes called a uterine septate, septate uterus. And these are the diagram showing these various abnormalities. Look at the uterine didelph, 2 horns of the uterus, 2 separate cervices. Uterus didelph, 2. And then you look at uterus monocornis, uterus bicornis biconix. You can see two horns of the uterus, fused body, but they are double cervices. Uterus biconix, bicollis. And in uterus biconix unicollis, uterus biconix, you can see the two horns. You can see the two horns of the uterus. There is some degree of fusion at the lower segment here, and then the cervix is normal. The cervix is normal. It's normally developed. Look at uterus septate. You can see a septate uterus. This is a longitudinal septate. So again, the horns. This regards to as biconate. You can see it, biconate. The cervix is normally developed. Look at a rudimentary horn. Rudimentary horn. This is a rudimentary horn. This horn is fully developed, right? And this is where you can have an ectopic pregnancy in a rudimentary horn. It's very common. Yes, uterus unicornis, in which case it's only one Mullerian duct that grows to form the fallopian tube, to form the uterus, and then the cervix. The other one does not exist. It does not exist. Vaginal septum. This is a vaginal septum. It's a vaginal septum. Vaginal septum may be complete or incomplete, and may occur with or without a double cervix. Sometimes there could be an elongated congenital elongation of the cervix. You see, the normal cervix is about 2.5 centimeters long, and when cervix is long, very long, it may affect fertility. In which case, that cervix is more than 3, 4, 5 centimeters long. There could be abnormalities of the fallopian tubes resulting from this embryonic development. They could be malformed, they could be excessively long, and they could occur with diverticular or accessory OCS. And sometimes they could be absent. And finally, abnormalities of the ovary could occur. There could be congenital dysgenesis, gonadal dysgenesis, or they could be completely absent. In conclusion, we have talked about the clinical or surface anatomy of the internal and external genitalia. We have also discussed the development of the internal and external genitalia, and we have also listed the types of malformations that can occur in respect of abnormal development of the internal and external genital structures. I thank you for listening.